All right, so welcome everybody to this first session of the ISE Young Communities webinar. And this session is about risk stratification of ventricular arrhythmias. The talks are 10 minutes each, so there's no time for questions after the talks, but at the end there's a 20-minute panel discussion. And if I'm not mistaken, I think the audience can ask questions at that time. Is that right, Gary?
Yeah, that's right, yeah.
Yeah. Okay, so Sharon, I would like to invite you to start with your presentation. The floor is yours.
Thank you, Professor Mark. Let me share my slides now. Can everyone see my slide?
Yes, perfectly.
Okay, thank you. Good evening, everyone. My name is Sharon, and it is my pleasure today to be presenting on the risk stratification in Brugada syndrome. Brugada syndrome is an inherited cardiac ion channelopathy that is associated with an increased risk of ventricular tachyarrhythmia and ultimately sudden cardiac death. It is diagnosed by its characteristic coved or saddle-shaped ST segment elevation in the right precordial lead. However, patients have a different risk of adverse events, and risk stratification remains to be difficult, particularly amongst patients of an intermediate risk. And there are many local opportunities for research in Hong Kong, precisely because the disease prevalence is higher in Asia, with a potentially good follow-up data amongst public hospitals, and high impact can be generated from multidisciplinary collaborations across medicine, engineering, and data science, which is what our team has been doing. The question of risk stratification remains in the use of implantable cardioverter defibrillators for primary prevention amongst Brugada syndrome patients. For patients who have never experienced ventricular tachyarrhythmic events, initial risk stratification is based on the presence or absence of syncope of cardiac or arrhythmic origin. Amongst patients with previous episodes of cardiac syncope, there is a Class 2A indication for the use of implantable cardioverter defibrillators. Whilst for patients with no cardiac syncope but with a spontaneous type 1 Brugada ECG pattern, other risk factors such as family history, Ecg markers, genetic findings, as well as arrhythmic inducibility on electrophysiological studies are considered. In patients where arrhythmia was not induced on electrophysiological studies, close monitoring is advised. However, if ventricular tachyarrhythmia can be induced, there is a Class 2B indication. However, there is regional differences in recommendation, which reflects the controversy in the use of electrophysiological study in the risk stratification of Brugada syndrome patients due to the heterogeneous evidence that was found. Furthermore, the type of syncope that's presented also matters. It was reported that patients who presented with syncope along with a type 1 Brugada ECG pattern is associated with a 4-fold increase in risk of ventricular tachyarrhythmia. However, those who presented with neurally mediated syncope had a more benign disease course than those who presented with cardiac syncope. Therefore, this highlights the importance to have detailed information regarding the clinical scenario, prodromal symptoms, and precipitators based on the description of witnesses and the patients themselves. There's also a potential role of intense rhythm monitoring using implantable loop recorders. It is also problematic amongst asymptomatic patients, although they were previously considered to be of low risk for sudden cardiac death. 7% of asymptomatic Brugada patients have suffered from appropriate implantable cardioverter defibrillator shocks over a 10-year period, suggesting that they're not as low risk as previously considered. In addition, in consideration of the ECG pattern presented, those who presented with spontaneous type 1 Brugada pattern is associated with a 4-fold increase in the risk of future arrhythmic events in comparison to their counterparts who had drug-induced type 1 pattern when they're asymptomatic initially. The placement of ECG leads high on the third intercostal spaces increases the sensitivity of detecting a type 1 ECG pattern. Spontaneous type 1 Brugada pattern in combination of cardiac syncope is considered to be high risk, but the counterpart of those who presented with spontaneous type 1 Brugada pattern but remain to be asymptomatic is considered to be low risk. This raises the question, are patients who presented with drug-induced type 1 Brugada pattern always of a low risk? It was reported that a significant portion of patients who presented with an aborted sudden cardiac arrest only have a drug-induced type 1 Brugada ECG pattern beforehand, indicating that this group of patients is also not as low risk as previously considered. In addition, as mentioned previously, there is a heterogeneous extent of evidence in the use of electrophysiological studies to evaluate the risk of sudden cardiac death amongst Brugada patients. The annual ventricular tachyarrhythmic event risk of patients who had inducible ventricular tachyarrhythmia on electrophysiological studies vary substantially, also based on syncope history and the presence of spontaneous type 1 Brugada pattern. What all this reflects is that multi-parametric models should be used in the evaluation of sudden cardiac death risk amongst Brugada patients and not just single parameters. Other parameters, such as Ecg markers, include the following, such as a positive R wave in AVR lead, where R wave amplitude is greater than 0.3 millivolts in the lead AVR, or early repolarization pattern in peripheral lead, S wave in lead 1, where it is greater than or equal to 0.1 millivolts and or greater than 40 milliseconds, a fragmented QRS interval or prolonged QRS, corrected QT, and TPTN intervals. As mentioned previously, patients who were considered to be of an intermediate risk of sudden cardiac death were actually along a spectrum of risk, and therefore it remains to be difficult to stratify the risk for this group of patients and to make the clinical decision of whether or not this group of patients should have implantable cardioverter defibrillators implanted. Therefore, many clinical risk scores have been developed to try and address this problem. For example, the Shanghai score, which was originally developed for the diagnosis of Brugada syndrome, has been recently tested for its ability for prognostic prediction. Other scores, such as those by Lees, Sierra, Lessis, and the Brugada risk score, and many others, have also been developed. And the Sierra and Shanghai scores have been externally validated. This is an overview of the different risk scores developed and the different parameters that they have included in the scores. Recently, our collaborative team have also developed a score ourselves, in which we've included the hot location of SCN5A variants into the score to employ a more personalized approach. Although SCN5A mutations do not occur in all patients, by including genetic findings, it has allowed improvement in the accuracy of the risk score to an AUC of 0.891. Suggesting that to incorporate genetic information into the use of clinical risk score can help to improve the accuracy of prediction by making it more personalized. Based on these findings, our team has worked on the genetic basis of Brugada syndrome, with recent works focusing on the use of clinical, ECG, as well as other investigations for risk stratification. We've also found that serial ECG testing can be helpful, since higher temporal variability in ECG markers can reflect higher arrhythmic risk. There's also found to be a difference in ventricular tachyarrhythmic risk during follow-up between those who presented early in their childhood versus those who presented in their adulthood. We've also found that the risk prediction is further improved by the analysis of automated ECG data, as well as the application of machine learning methodologies. A recent work of ours was to develop a multi-parametric risk score using local Hong Kong data. First, we validated the existing scores using local data, and within which we found the best performing score with the highest AUC, which was the Sierra score, and we incorporated additional significant variables that were found on a univariable Cox regression to develop what we called the modified Sierra score. And because electrophysiological studies were not routinely performed in Hong Kong, a simpler score, what we named the novel risk score, was created by excluding sinus node dysfunction as well as electrophysiological study findings, And we put these models through our cohort to predict for ventricular tachyarrhythmic events during follow-up. What we found is that the modified CRS score, when put through the whole cohort, intermediate risk subgroup, primary prevention subgroup, as well as patients who undergone electrophysiological study testing, has demonstrated to have a superior predictive performance. In the future, we wish to incorporate genetics into risk stratification in order to make the process of sudden cardiac death risk stratification for Brugada patients much more personalized in order to improve the accuracy in prediction, not just limiting to SCN5A variants, but also to other mutations as well. There are also many opportunities for international collaboration in Brugada syndrome. Our team has been constructing a Brugada ECG Indices registry, and currently we have over 1,500 cases with Brugada pattern already recruited from 43 centers in 21 countries. And we're happy to include any number of Brugada pattern cases with ECG measurements, clinical characteristics, investigation results, and with spontaneous ventricular tachyarrhythmic outcomes. If anyone in the audience would be interested in joining our registry, then please feel free to contact me or Professor Gary there. In conclusion, a multi-parametric approach should be used for the risk stratification of Brugada syndrome. And the most difficult subset are those who are considered to be of a low or intermediate risk. Sudden cardiac death is a traumatic experience for both the patient and their family members. So even a very low risk is considered to be a very significant one, as the event is terminal. Whilst there are many scores available, there's only a handful that has been externally validated. And the roles of genetic testing and machine learning algorithms should be considered to improve the predictive values of existing scores. At the end, I would like to thank my supervisor, Dr. Gary Faye, as well as our team members, both our local and international collaborators. And thank you for your attention.
Hi, Mark, you're mute.
Thank you. Sharon, thank you for your presentation. Let's go on to Levent's talk. Levent, the floor is yours.
Thank you, Mr. Potse. Hi, everyone. My name is Levent. And can you see my page clearly now?
Yes.
Okay.
Perfect.
My name is Levent Pay from Turkey. First of all, I would like to thank to ISE Council for giving me the opportunity to present at this great Congress. Now I will present the risk stratification of long QT syndrome. Long QT syndrome is one inherited cardiac condition characterized by a phenotype of QT prolongation on the ECG and an increased risk of life-threatening ventricular arrhythmias such as torsade de pointes or ventricular fibrillation. Long QT is caused by altered expression or function of repolarizing ionic channels, mainly loss of function, potassium channels mutations, or gain of function, sodium or calcium channel mutations that result in reduction of net repolarizing currents. The first descriptions of long QT syndrome identified two patterns of inheritance. First, the more common autosomal dominant variant, Romanov-Ward syndrome. The second one, the rare and several autosomal recessive variant, Jervell and Lange-Nielsen syndrome, which is accompanied by congenital deafness. According to the current guidelines, one of the following three criteria is required for the diagnosis of congenital long QT syndrome. 1. Long QT risk score 3.5 at least, and absence of secondary causes for QT prolongation. 2. A corrected QT interval 480 to 500 milliseconds on repeat ECGs in the absence of secondary causes for QT prolongation. And the 3, the presence of pathogenic genetic long QT variant irrespective of the corrected QT duration. Here is the scoring system that depends on ECG clinical history and family history. Patients with a score of less than 1 point are in the low risk group. However, patients with a score of higher than 4 points are in the high risk group. Hereditary long QT syndrome is characterized by dysfunction of various cardiac ion channels, resulting in abnormal myocardial repolarization with prolongation of the action potential. Those repolarization abnormalities are more pronounced in the endomyocardial and midmyocardial layers and create a transmural repolarization gradient. This transmural dispersion of repolarization represents a proarrhythmic electrical substrate predisposing to triggered activity that may result in torsade de Puentes or polymorphic ventricular tachycardia. Long QT syndrome is the most common inherited arrhythmia. Although there are many defined subtypes, long QT subtypes 1 to 3 represent 75% of all cases. The first 2 subtypes are based on function, loss of function variants in the potassium channel genes KCNQ1 and KCNH2 respectively. Long QT syndrome type 3 is based on gain of function variants in SCN5A, the gene coding the fast inward cardiac sodium current. Rapid progress of genetic technology over the past 2 decades has significantly improved our understanding of molecular and genetic mechanisms of long QT. Despite all those novel insights, phenotype assessment and appropriate risk stratification in long QT remains challenging even for the experts. Risk stratification is traditionally focused on the probability of a cardiac event before age 40 years, and the generation of risk groups are phenotype-genotype guided. Risk stratification in long QT is complex, including demographic elements, clinical and genetic markers. At present, clinicians rely on many factors, including phenotype and genotype characteristics, combined with the surface ECG to guide risk stratification and management approaches. Genetic and clinical elements influence risk assessment in individuals with long QT syndrome, with several patterns and groups associated with differential risk. The risk of cardiac events is significantly higher in patients with long QT2 and long QT3 than patients with long QT1. On the other hand, adrenergic triggers, particularly exercise and swimming, are the most important trigger for arrhythmic events in long QT1, whereas in long QT2, sudden arousal is predominant. Events in long QT3 occur most frequently in rest. Genetic testing has evolved beyond a pure diagnostic tool and is in addition increasingly integrated as a complementary prognostic marker. A high risk of death in long QT syndrome is present among patients with mutations in the KCNH2 and in the SCN5E genes. Mutations in the transmembrane region or cytoplasmic loop are associated with more frequent cardiac events than those in other regions. Cardiac events tend to occur more frequently in childhood, and at this age, male long QT syndrome patients have a high risk and earlier onset of events than females. In adulthood, although the risk of cardiac events is decreasing, there is a gender-related difference. Female long QT syndrome patients experience more events than males. Sex had no influence among long QT1 patients, whereas life-threatening events were higher among long QT2 females and higher among long QT3 males. High risk is also present whenever corrected QT duration higher than 500 milliseconds and becomes extremely high when corrected QT duration higher than 600 milliseconds. The presence of T-wave alternance is a sign of electrical instability and also identifies patients at particularly high risk of events. The onset of symptoms occurs at a mean age of 12 years old with an earlier onset usually associated with more severe outcomes. On the other hand, it was shown that patients with syncope under beta blocker therapy had a relative high risk for developing sudden cardiac death. Non-adherence to beta blockers is still one of the most important risk factors for cardiac events. A strict avoidance of any QT prolonging medication is crucial, and the verification of any given substance with a pharmacist is recommended prior to administration. Other routine measures should include the avoidance of significant electrolyte disturbances or typical trigger situations for arrhythmic events, for example, abrupt loud noise for long QT2. The decision about sport participation should be individualized and requires a comprehensive assessment by an expert in inherited arrhythmia. Long QT syndrome still remains the most common and most extensively studied channelopathy, affecting approximately 1 in 2,500 individuals of the general population. In summary, individualized management of patients with long QT is crucial. Risk stratification in patients with long QT syndrome should include genetic evolution, corrected QT duration, number of cardiac events before age 18, age of first cardiac event, and assessment of recurrence of ventricular arrhythmia on appropriate beta blocker therapy. Thank you for your attention. Thank you, everyone.
Thank you, Levent. So the next presentation is by Ishan Lakhani on risk stratification in pericarditis. Ishan, please go ahead. And Tong, would you like to chair the session after me, after this talk?
Okay.
Hi, can everybody see my screen?
Yes, you can start in the presentation mode if you like. That would be clearer.
Yeah, okay,
Yeah,
great.
perfect.
Okay.
Thank you.
All right. Good afternoon, everybody. Thank you for inviting me to talk at this conference. And today I'll be talking about risk stratification in pericarditis in relation to the risk of ventricular arrhythmias, but with particular focus regarding a study that our team just performed in Hong Kong. So acute pericarditis is an inflammation of the pericardial layer of the heart. It's an immune-mediated clinical condition that is often unrecognized and associated with numerous complications. Etiologically speaking, pericarditis can be divided into infectious causes, which primarily include viral, but also bacterial, fungal, and parasitic species, as well as non-infectious causes, including metastatic malignancy, connective tissue diseases like lupus or rheumatoid arthritis, as well as other metabolic conditions like uremia. Pericarditis itself is characterized by a typical symptomatic presentation that includes pericardial chest pain, which is worse on recumbency and improves when the patient leans forward, pericardial friction rub, and possibly pericardial effusion, as well as serial ECG changes that typically involve diffuse ST segment elevation, PR segment depressions, and T-wave inversions. Now, several cohort studies have explored the underlying pathogenesis, clinical presentation, and risk factors leading to pericarditis-related admissions, but only a few studies have actually explored atrial and ventricular arrhythmic outcomes in such cohorts. This is a relatively unexplored area in the context of pericarditis. So some investigations of late have made use, as Sharen previously mentioned, of automatically measured ECG parameters to evaluate such relationships, as unlike manually measured ECG variables, the automated techniques are not limited by inter-observer bias, and they allow for the extraction of parameters that would otherwise be difficult to obtain manually. So the particular investigation that I would like to discuss in relation to ventricular and general arrhythmic outcomes in pericarditis involves a study that our team recently performed to investigate the role of automated ECG parameters in predicting not only malignant ventricular arrhythmias like VTAC and VFib, but also atrial fibrillation, heart failure with reduced ejection fraction, and all-cause mortality in a cohort of pericarditis patients. So just briefly, methodologically speaking, we performed a territory-wide retrospective cohort study of pericarditis patients with baseline ECG measurements taken from Jan 2005 to December 2019 in Hong Kong. And patients were identified, essentially the pericarditis patients, they were identified by ICD coding using our nationwide clinical data analysis and reporting system, also known as CDARS, which is a territory-wide database that essentially centralizes the patient information from about 43 local hospitals, along with their associated ambulatory and outpatient facilities, to establish comprehensive medical data, including clinical characteristics, disease diagnosis, laboratory results, and drug treatment details. This information was then synchronized with data retrieved from another system, the clinical management system, which included demographics, prior comorbidities, medication prescription, and various laboratory tests and blood counts. Now, we also retrieved automatically measured ECG parameters relating to the P wave, the QRS complex, and the T waves for each of the included patients. Just briefly on our actual cohort. So we included a total of 874 patients, and the cohort was 50% male, median age of 59 years. Subjects who developed VTAC tended to have baseline VT or VF prior to the diagnosis of pericarditis. And regarding the blood parameters, patients with VT-VF also reported higher eosinophil counts, higher LDL levels, elevated levels of high sensitivity troponin I, as well as higher lactate dehydrogenase levels, along with a lower mean corpuscular volume. During follow-up of this group or pericarditis patients, 57 patients suffered from VT-VF, 156 developed AF, and 168 developed heart failure, respectively. And a total of 396 patients, so almost 50% of our cohort passed away, of which 52 individuals were cardiovascular-related etiologies. So I just want to give a brief introduction about automated ECG parameters for people who might not be aware. So Table 2 describes and explains some of the major automated ECG parameters that are typically used. And these variables, as I previously stated, cannot be derived manually, and they require a computerized software for calculation and for extraction. As such, basically, very few studies have actually assessed the prognostic use in risk stratification of these variables for evaluating clinical outcomes in disease states, because the technology is, I guess, rare. And for the interest of time and simplicity, I just want to draw your attention to the top half of this table, which essentially demonstrates the QRS vector magnitude parameters in millivolts. So the QRS vector magnitude in particular is of late becoming a progressively popular variable for use in outcome analysis. And as we know, the QRS complex reflects ventricular depolarization, and its vector in turn represents the major vector of ventricular activity, the average of all the depolarization vectors, if you will. Now, recently, there have been a few published studies that have showcased an association between a smaller QRS vector magnitude and mortality in heart failure patients, as well as with ventricular arrhythmias in both Brugada syndrome and tetralogy of Fallot patients. Now, initially, it might come as somewhat of a surprise that a lower rather than a higher QRS vector magnitude has shown to demonstrate outcome associations. The current school of thought for this supposes that the underlying pathologies of the heart cause a dispersion in the normal ventricular depolarization, which in turn leads to a reduction in the unidirectional force and in turn the QRS vector magnitude. Now, based on this hypothesis, coupled with the findings suggested from previous studies, we attempted to assess the prognostic value of not only a parameter such as the QRS vector magnitude, but also several other automated parameters in the context of pericarditis for the purposes of risk stratification. So just on to our results. So Figure 2 shows the Kaplan-Meier analysis for incident VT-VF. And Table 3 displays all the parameters that were included in our multivariate model. Variables that retained significance after multivariate adjustment, along with their hazard ratios, confidence intervals, and p-values are highlighted in red. So as can be seen from Table 3, we were able to find a total of 3 parameters that were univariate predictors of incident VTVF in our cohort of pericarditis patients, with baseline VTVF and a mean QTC interval duration retaining significance in multivariate prediction. Table 4, which assesses the risk of new onset AF and demonstrates an abundance of variables that were found to be associated with new onset AF in pericarditis, with baseline age and the mean PR segment duration showing a positive association after adjustment. And regarding the prediction of new onset heart failure in pericarditis from table 5, we can see that the presence of comorbid hypertension, ST segment horizontal axes, atrial rate, as well as the mean QTC interval were again all predictors of heart failure development. And finally, as it pertains to all-cause mortality, so the Kaplan-Meier analysis can be seen in figure 5, and as it pertains to all-cause mortality from table 6, we can see that baseline age, the maximum magnitude of the QRS vector in the transverse plane, the mean ventricular rate, and the mean PR segment duration all retained significance in multivariate analysis after adjustment. So just briefly to sum up, so the reason why I decided to perform a talk on our recent investigation is because there isn't much information or much data on the risk stratification in terms of ventricular and other arrhythmic outcomes in pericarditis patients. And from our study, it seems that AF and heart failure are seemingly more common complications in pericarditis, with ventricular arrhythmias occurring less frequently. And from our studies, we were able to identify different clinical and ECG parameters associated with these outcomes, as well as all-cause mortality. And in particular, we were able to further confirm the long-established relationship between QTC prolongation and VTVF, as shown in various other studies. Further, we also demonstrated an association between the QRS vector magnitude with all-cause mortality in the context of pericarditis, just as existing literature has done with other notable cardiac conditions, namely heart failure. And we were also able to demonstrate an association between the PR segment duration and AF development within the context of pericarditis, akin to existing literature that has shown an association between AF and the PR interval, of which obviously the PR segment is a component. So many ECG parameters, as I've stated, have long been established to be associated with pericarditis, with particular focus on their diagnostic value. So this study is among the first to not only expand upon these parameters with the use of automated measurements, but also to suggest their prognostic capacity in evaluating several long-term clinical outcomes. So the use of automated parameters could be a potential area to explore in the future, and it could be where risk stratification primarily lies, because it allows for the true wealth of the information provided by the ECG to be explored and extracted. The automated parameters, they reflect on the most minute level the pathological electrical disturbances that underlie many cardiac conditions, thereby providing them with value in using them to evaluate not only arrhythmic outcomes, but also long-term general outcomes like all-cause mortality. Now, granted, further investigations are still needed to understand the underlying nature of these parameters, and only with this validated evidence can we actually consider implementing these parameters for risk stratification in the clinical setting. Thank you.
Thank you. So next speaker will be Anna. Her speech is risk stratification in heart failure patient. Welcome.
Good afternoon, everyone. It is an honor and a pleasure to participate in this, to be part of this first young community meeting. My mission would be to briefly review the risk stratification, the rhythmic risk stratification in heart failure. And despite major improvements in cardiovascular care in the last 30 years, the sudden cardiac death continues to be a major international problem, accounting for a quarter of deaths. The major advance in the prevention strategy has been the development of the implanted cardioverter defibrillator. But currently, the indication of ICD is based on studies that targeted subgroups of patients with a high incidence of sudden cardiac death, those with heart failure, with reduced ejection fraction, the cardiac arrest survivors, and patients post myocardial infarction. But the majority of the sudden cardiac death events occur in patients who are considered as low-risk events, who cumulatively account for the greatest number of events. It has been estimated that more than one third of all sudden cardiac deaths occur among patients with known heart disease, whose ejection fractions are more than 35%, without other known arrhythmia and risk markers. So right now considered at low, not so high risk arrhythmic risk. Another 30% or more are first clinical expressions of unrecognized heart disease, mostly coronary artery disease. The current definition and classification of heart failure comprises three categories based on the left ventricular ejection fraction. The heart failure with reduced ejection fraction, mildly reduced ejection fraction, and preserved ejection fraction. It is well known that the heart failure with reduced ejection fraction poses an increased risk for sudden cardiac death and ventricular arrhythmias, and this risk is increased irrespective of the etiology. Although we will see that not uniformly. The rates of sudden cardiac death, though, in this category decreased over the last 30 years by 34% due to advances in methods of prevention, especially of prevention of coronary artery disease, and to heart failure treatment strategies, including both medical and interventional treatment strategies. And these advances limited both the incidence of ventricular arrhythmias and the disease progression. But the sudden cardiac death occurs in the larger population of patients with preserved ejection fraction. And we have data from multiple randomized trials and epidemiological studies in which sudden cardiac death consistently accounted for about 1/4 of the deaths. The pathophysiology of sudden cardiac death in heart failure is complex and results from interactions between both the functional and structural changes that alter the electrophysiological properties of the myocardium and result in electrical remodeling. And the interaction of such a vulnerable substrate with multiple transient contributing factors in heart failure, as electrolyte disturbances, cathetic activation, hemodynamic distress, and the hypoxemia participate in triggering the fatal event. The current indications for implantable cardioverter defibrillators for sudden cardiac prevention in heart failure patients rely almost entirely on left ventricular ejection fraction. And these parameters prove to have many limitations, right? Related to reproducibility, accuracy, geometric assumptions, related to its dependency on loading condition and heart rate, and also experience of the operator and echographic window. In addition, the left ventricular ejection fraction appears to be more robustly related to total cardiac mortality than to sudden cardiac death. As discussed earlier, depressed ejection fraction constitute only a minority of the sudden cardiac death cohorts. Also, use of low ejection fraction alone as a criterion in a patient's selection for ICD may both lead to unnecessary ICD implantation and deprive other high-risk patients from effective sudden cardiac death prevention. Thus, new stratification strategies are needed. In addition to the official guideline recommendations regarding the risk stratification strategies in heart failure, there's an increasing body of literature that describes other risk stratification too, and we have multiple non-invasive and also invasive strategies tested throughout time, especially in heart rate heart failure with reduced ejection fraction patients with many promising results. These are well-established risk factors for sudden cardiac death prediction in heart failure with reduced ejection fraction, but not all were validated in preserved ejection fraction cohorts. Also, they have different predictive value in heart rate in heart failure with reduced ejection fraction with respect to the ischemic versus non-ischemic etiology. These parameters have so far had limited use in the clinical setting, and most probably multimodality, multi-parameter algorithm is needed to improve risk prediction. A recent publication further challenges the current practice. This is the Danish study, was a randomized controlled study including patients with heart failure with reduced ejection fraction and non-ischemic cardiomyopathy that compared ICD with the optimal medical treatment strategy, including the resynchronization therapy. And although with a significant reduction in the sudden cardiac death in the ICD group, there was no overall survival benefit noted following ICD implantation in dilated cardiomyopathy population with reduced ejection fraction compared to optimal medical therapy. Furthermore, the techniques incorporated in traditional arrhythmic markers provided only modest risk stratification for sudden cardiac death in patients with reduced ejection fraction and non-ischemic dilated cardiomyopathy. These are the results from a meta-analysis published in 2014. And the best predictors of arrhythmia risk were T-wave alternance, the left ventricular and diastolic dimensions, inducible ventricular arrhythmias at electrophysiological study, late potentials, and the left ventricular ejection fraction, the duration of QRS, and non-sustained ventricular tachycardia on Holter monitoring. Autonomic function parameters as heart rate variability and heart rate turbulence were not statistically significant predictors in this population. And the authors concluded that probably combining tests will optimize the risk stratification in this population. For HFpEF, data is limited and mostly is on patients with coronary artery disease. T-wave alternance associated with increased arrhythmic risk in a prospective study in HFpEF with patients with MI. The PRESERVE study showed that the combined non-invasive risk stratification approach in patients with HFpEF with mildly reduced and HFpEF patients with MI might be useful with a negative predictive value of 100% following this two-step approach. The first step with non-invasive markers, and the second step for those who had one risk factor in the first step with electrophysiological study. And also magnetic resonance imaging can also be helpful for patients with dilated cardiomyopathy with mildly reduced or normal ejection fraction. The myocardial scar burden on contrast enhanced myocardial magnetic resonance imaging showed to be superior to left ventricular ejection fraction for prediction of ventricular arrhythmias in many studies. And integrating the late gadolinium enhancement and left ventricular ejection fraction and clinical algorithm significantly improved the risk stratification for sudden death, providing relevant implication for ICD allocation in a study published in 2012. Recently published meta-analysis published in 2017 in JACC that included patients with dilated cardiomyopathy and a range of mean left ventricular ejection fraction between 20 and 43%, showed that there was a significant association between late gadolinium enhancement and sudden cardiac death and ventricular arrhythmias, both when the left ventricular ejection fraction was below the cutoff of 35%, and also when it was more than 35%. So late gadolinium enhancement seems to be a good predictor of arrhythmic risk. Finally, in recent years, advances in myocardial deformation imaging led to identification of more sensitive echocardiographic parameters. The improved study that included patients with HFrEF with both ischemic and non-ischemic cardiomyopathy found that strain-derived parameters, global longitudinal strain and mechanical dispersion, are independent predictors of sudden cardiac death, irrespective of the etiology of the cardiomyopathy. And mechanical dispersion with a cutoff of 70 milliseconds had an improved precision compared to left ventricular ejection fraction. The highest arrhythmic risk was registered in the group of ischemic cardiomyopathy and mechanical dispersion more than 70 milliseconds. And another important finding was that the non-ischemic cardiomyopathy patients with low mechanical dispersion had an arrhythmic rate close to the general population. After this brief update, the messages to take home would be that although the current indication for ICD in heart failure patients are based on the left ventricular ejection fraction, these parameters has a lot of limitations, and the traditional well-established risk factors for predicting sudden cardiac death in HFrEF patients had controversial results in HFrEF, and the appropriate risk stratification this latter category, this latter population remains unclear. And promising results using there are promising results using multimodality, multi-parametric algorithms for arrhythmic risk stratification in the different phenotypes of heart failure that we have to wait to be assessed and to get into our guidelines. Thank you.
So thanks, Anna. So let's move to the panelist discussion. Welcome. We have two panelists to join us, Elena and Tachapong.
Hi everyone, I'm Tachapong. Sorry I'm late. I thought it was GMT, not +1. But anyway,
welcome.
Great, thank you for the invitation. Love to join everyone.
So we have a full presentation today in this session. Maybe we had some discussion during for talks.
Yeah. So if I may, I would like to ask a question to Sharen.
Please.
Yes.
So you said that Brugada syndrome is an inherited channelopathy. So I was and then you introduced all these very difficult ECG analysis methods with not so very good results. So I'm wondering if it's an inherited channelopathy after all. Why don't you just test for the mutation?
It's actually quite an interesting question, because there are recent studies that finds where there are people who have these mutations, but they do not have the phenotypes of Brugada syndrome, whereas there are patients who presented with Brugada syndrome, but without the certain genotypes that were currently discovered. So although the hereditary factor plays a major role, in particular when we look at the family studies of these patients, there are, first of all, a lot of genetic factors that have yet to be discovered and genetic factors that interplay with each other. And on the other hand, could there also be environmental stimulus that also plays a part in terms of the manifestation of these phenotypes? Just why the discussion of incorporating genetic findings come to play.
Yeah, I think so. I think that 70% of the people with the Brugada phenotype don't have a known mutation. Is that right?
Yeah, and it also comes down to the prevalence of genetic testing. Actually, in Hong Kong, around only 30% of the patients actually get genetically tested, unfortunately, due to resource limitations, as well as whether or not the patients are willing to get tested. So whether or not the percentage of patients with the genotypes found is also highly dependent on whether or not they get tested at all.
Yeah. Okay, thank you.
Well, Dr. Lee, I was going to say that, that 30% is much better than in Thailand. We almost really, and really you get into a clinical study or genetic study trials, none of the patients in Thailand get genetic tests. And that, I guess, is, from my perspective, is one of the major limitations doing genetic tests in Brugada syndrome, in at least in the part of my world where genetic tests is really difficult. Now, I've heard lately that the genetic tests after the ClinGen things, there's only one left that's significantly, only SCN5A that has significant impacts on Brugada syndrome. What's the latest update on that?
I think currently we're not just looking at SCN5A, although it is one of the major sources of genetic mutation we're looking at, but there are also other sources of mutation that is also explored, and that's why NGS testing was introduced as well. And in Hong Kong, although again, it's really mainly due to resource limitation. In the public setting, we mostly sought for SCN5A testing, but that is more due to the availability of the tests. If the patients have the resources, we do recommend them to go for NGS testing overseas or in a private setting, and we do refer them to do so.
For practical purpose, I guess somebody has questions. Was it Gary?
Oh yeah, it's me. Yeah, thanks, Tachapong.
Hey Gary.
Hi, thanks so much for coming.
Good to see you.
Just to answer your question and to supplement Sharon's very good answer. So there was the APSE meeting that you very kindly introduced me to, and there are a few investigators who have started proposing the effects of gene dosages. So even though SCN5A might be the main contributor, if you've got mutations in other genes, such as calcium channel genes or potassium channel genes, even though those mutations alone may not be pathogenic, if there are slight variants that affect channel function, it could be SCN5A as well, and all the effects might be synergistic additive to produce a phenotype. And of course, there's something that we missed from the Ecg study that Sharon presented. I think Mark was alluding to that, which is the dynamic nature of the disease. So obviously, Brugada syndrome, the risk changes with different autonomic tones, changes with stress, changes with fever. But at the moment, all of the ECG parameters were measured at baseline. So what we need is, to have potentially serial ECG recordings, to have that captured during stress times and during periods of elevated arrhythmogenicity, which we've failed to do so far. So there's definitely a lot more work to be done.
Great. No, that's very clear, Gary. What's the? I guess I think it always comes down to the most difficult case is those asymptomatic patients. The one with symptoms are usually quite easy.
Yeah, it's really difficult. The intermediate risk groups, it's what is an acceptable risk? If you tell them they're low risk and then sort of die 10 years later, then you'll be in trouble. And
I'll be retired.
Yeah, and you have a bigger problem than we do in Thailand, because presumably your prevalence is so high, then it's the numbers actually do add up, even though they're low risk.
Right. And then I absolutely agree. In someone who their risk is about 1% per year, I mean, over time, that's like 10% over 10 years. And it's something that's, need a lot of discussion between you and the patient and the family.
Very difficult.
So I have one question for Ishan. So for Ishan's talk about the ECG parameters in patients with pericarditis. So I'm wondering how many patients with early repolarization, like a J-point elevation, in that kind of patient, because we always see a lot of patients with following cardiac surgery. There's the pericarditis with the J-point elevation and the early repolarization. Maybe and also can influence the long-term prognosis.
So the parameters that we collected were a relatively set of parameters that were basically just computer generated. So unfortunately, we didn't have parameters that were necessarily, we didn't have parameters such as the J-point elevation. But in terms of repolarization abnormalities, so we hypothesized that because of the underlying electrophysiological disturbances that might result, these can be reflected in the ECG. And one of the parameters that we were able to showcase this was in the axial measurements. So we had we took measurements of the ST segment axes. So these are basically quite a few of the parameters that Gary's showing. So we took measurements of the ST segment axes, which of course is a segment abnormalities in which can represent can represent basically disturbances in the repolarization process. But as I said before, like the ECG parameters in pericarditis they've somewhat only been used in a diagnostic context rather than a prognostic context. So I feel that this is a good area to explore, namely because these electrical disturbances could be directly related to, I guess you could say, the pathogenic route from when you have pericarditis to when you have your outcomes. So if we can have these ECG parameters that, in essence, on the most minute level, reflect those electrical disturbances, then they should be able to predict these outcomes.
So I think there's a very important limitation for this study is maybe I didn't see the patient with comorbidities in this group of patients, such as how many patients with the coronary heart disease and heart failure. And I see as your group patient with a very high incidence of mortality, nearly 50% during follow-up. For maybe this the groups are very sick patient compared with others, the pericarditis.
So actually, in terms of the comorbidities, we did collect the patients who had baseline hypertension, diabetes, acute myocardial infarction, rheumatic heart disease, rheumatic disease in general. So we did collect a good sort of comorbidities, and we did incorporate it into the analysis. I just didn't show it on the presentation because either the variables, a majority of those variables were not significant when we performed our analysis. I think the main limitation with our study actually is that we didn't necessarily stratify the pericarditis cohort by etiology. And of course, the underlying etiology can, without a doubt, influence whatever outcome, may result. So I think that would be the predominant limitation. So as of right now, so this is basically our first pericarditis study. So subsequently, we hope to stratify patients on the basis of whether they have infective causes, whether they're inflammatory causes, connective tissue disease-based causes, and then hopefully we can get a clearer picture.
Gary, it's 2:15. Should we move on to the next session? And do we have to go to another meeting for that?
No, so the link's actually the same for the atrial arrhythmia meeting. So if everybody can just stay on, that would be amazing.
Yeah.
Thanks.
Okay, thank you.
Okay, thanks everybody.
Thank you.
So much.
Thank you.